Topbed Talk.
So our next speaker is Andrew Bates from Royal Bournemouth and Christchurch Hospitals NHS Trust, and he's going to talk about a 2-week exercise prehabilitation for patients facing primary surgical resection of colorectal cancer, and it's a feasibility trial.
Thank you. So I am Andrew Bates, but I've got a new role. So I currently now work in University Hospital Southampton with Sandy, Mike and Denny on their Fit for Surgery consortium. But in my previous role, I was a research nurse at Royal Bournemouth Hospital and got involved with a group who were interested in prehabilitation. And our particular cohort of interest were colorectal cancer patients. We felt they had a very narrow window of opportunity to exercise these patients prior to surgery. And they were also our largest cohort of patients at this District General Hospital. So with all good research, we just looked a little bit at what we know. 20,000 patients a year having primary surgical resection for colorectal cancer. Around a 2% 90-day mortality rate, but quite a persistent 15% of those patients will have prolonged morbidity post-operatively, and around a 15% 90-day readmission, emergency readmission. And we know that also that projects forward to not just a long-term impact on their health-related quality of life, but also from mortality up to 2 years later. We also know from pioneering work from Paul Alder that objectively measured physical fitness from CPET is predictive of post-operative outcome. If you're less fit, more chance of post-operative complications. And some more contemporary research in our particular cohort from Malcolm, Sandy and Mike. And it all led to the issue of we really need to prehabilitate our patients, which is why everybody's here today, so everyone's bought in. And it's all the evidence is neatly summarised in the special edition of Anaesthesia, which came out in January of this year. What we very quickly became aware of was certainly our local experience is that we're time crunched. So we're all working in the UK. In the UK, we're working with a 62-day time to treatment target. And what we knew from our hospital, and it's borne out in this national data, that you can see we've got a reducing number of clinicians who are, this is radiographers and this is radiologists. So we've got an increasing patient demand and a reduction in diagnostics. And what that does is squeezes the window for prehabilitation. So we set ourselves two very simple and straightforward aims. One, with such a narrow window of opportunity, would it be feasible to recruit patients? They've just received devastating diagnosis, and they don't have an awful lot of time before surgery and a blizzard of appointments potentially to take care of. Would they be safe, and would the patients undertake the exercise that we prescribed for them? And then we looked at a secondary aim, was in just 2 weeks, and I'm glad somebody asked a question earlier about this, because I can hopefully give some answer. Can we make some change in their objectively measured physical fitness? So we designed a purposefully very simple feasibility trial. The first thing that we did, and I would recommend this for anybody who's interested in prehabilitation, is get in with your MDT as quickly as possible. Map the pathway. Become very friendly with your CNSs, because they're the people who follow the patients all the way through, from first referral right through the rehabilitation phase. It turns out, I didn't realise at the time just how lucky we were, but in Royal Bournemouth Hospital, the CNSs make telephone appointments on the afternoon of the MDT. So on a Tuesday morning, you have the MDT. We would identify the patients as eligible for edict. The CNSs would make that phone call, which was pre-organised, to the patients. They would give them the diagnosis, which commonly didn't come as a surprise. They would give them the treatment options, which don't come as a surprise, and they would introduce edict and send them the patient information sheet, all done in that day. So there was no delay, which meant that I could phone the patients on the Wednesday, and if they were interested in coming in for the exercise trial, I could bring them in for consent and baseline CPET on the Thursday or Friday. Based on the physiological data that we got from the cardiopulmonary exercise test, we would prescribe them 6 exercise sessions over a 2-week period. Sandy very generously gave us license to use her high-intensity interval training sessions, which she's previously described and are now being used for WESFIT. And they would be delivered by our physiotherapists over 2 weeks. We'd then bring them back in for a repeat preoperative CPET to determine if there was a physiological change, and that was always done at least 2 days prior to surgery. 2 reasons for that. One, to give the patient time to rest before they went from one metabolic stress straight into another, and then, and secondly, bowel prep. So our results, in terms of feasibility, through the period, we were relatively short period of time. We had 214 patients came through our MDT. This was largely, we were an exceedingly small team doing this, so I only managed to screen 110 of those patients. The rest of the time I just had other stuff to do. Of the 110 patients, 52 were eligible, and they were all approached. Of the 30 who weren't ineligible, they were excluded because they just didn't have 2 weeks in which time to fit in the exercise training. Of the 52 I approached, 22 consented, which is a hit rate of 42%. 16 completed the study right through to the follow-up CPET. 3 dropped out to what I'm euphemistically referring to as cycling discomfort. 2 patients, really unfortunate, this one on the day. They were both coming in for their repeat CPET on the same day, and we just had equipment failure. We needed a new computer. So that was very unfortunate. And 1 patient had an unexpected medical investigation at the time he was supposed to be coming in for CPET. Of the prescribed exercise, 90% of the sessions were not just attended but completed. And there were no safety events. In terms of physical fitness, so our mean change in anaerobic threshold for the 16 patients was 1.33 mils of oxygen per kilo per minute. Simple t-test, we acknowledged quite a wide confidence interval, but we were statistically significant with a p-value of 0.016. So there's a definite hint that you can affect change in 2 weeks, and there's a graphical representation here. From baseline anaerobic threshold to pre-op anaerobic threshold, and this is AT up on the y-axis. I will just point out these 3 patients here who appeared to lose fitness. These were blind assessed, these CPETs, so we did a post hoc analysis with a level 3 accredited POETS clinician. And the best we can come up with, we have looked at these patients, is that we think that they're in the non-responder group. There was no drop in HB, there was no change in body weight or obviously tumour progression or anything. And I think they're worthy of a study in their own right because it correlates with normally about a 20% non-responder rate for all of these trials. And so what can I say that's new from all our efforts? Well, certainly I think we've demonstrated that it is feasible. There is certainly patient appetite for this in spite of everything that's going on for them. They do turn up. They are safe. The issues you're going to have is capacity in terms of staff. Time to surgery is crucial. You might want to buy some gel seats for your bikes. And you've got to train your staff. And I think it's plausible to suggest that we can affect some change to physical fitness with all the usual caveats about a small single-centre, single-arm trial. But of course, we're very, very proud that this data has been used and is going to be tested in a large multi-centre trial from Sandy, which is WesFit. Thank you very much.
Thank you very much. That was exactly on the button of 8 minutes. How you did that, I don't know. Congratulations. As a physiologist, I have a question. You don't report VO2 peak. Did it do a similar directional change? Did you actually look at those data?
No, not formally, no.
Okay.
Anecdotally, what I would say is that I think that there's a practice element to it. So I think patients, from what I could see, patients would push themselves harder on the second CPET. Mm-hmm. There was some determination there, but we didn't formally investigate it.
Right, we have some questions here. I guess I could pick... Oh, there's a lot of questions here. Well, this is a practical one, which is an important one. Who does the CPEX, and is it the same person doing and reporting the second test?
So I did the CPEX, CPET, and so I was the same person who did the baseline and the preoperative CPET every time. And we had a consultant anaesthetist, Richard Green, who's not here today, but he's a level 3 POETS accredited, and he would determine the the physiological variables on which we base the exercise training.
And just one final question, which actually is, I think, quite an important question. You don't report a control group?
No. We just wanted this to be a feasibility to test whether we could get patients to train for 2 weeks.
Right.
We weren't investigating those outcomes themselves.
Okay. Well, thank you very much. It was a great presentation, and we'll move on.
David Jerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com, and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.